So now I will start admitting people
Okay.
because we have a bunch in the waiting room.
I think you only can see that. Yeah.
So let me share now the video until maybe we can wait like 3-4 minutes before we start our event. We will share this video with our audience.
Sì,
I think we can start now. So welcome to all our audience. Thanks for giving your time to come and maybe discuss, share, and learn from our esteemed speakers. So we have audiences from many regions this night with a big differences in time frames. However, the intention to share knowledge always crosses the barriers. So let me start this event with a big congratulations to the King Fahad Medical City for their great achievement on HIMSS IMRAM Stage 7 accreditation. KFMC is one of the only 5 hospitals in Saudi Arabia to achieve the highest stage against the current criteria for validation. Congratulations, Dr. Abdullah. Congratulations, the KFMC. Let me now introduce our smart and dedicated moderator, Dr. Aya Jalabi. Dr. Aya is a senior consultant at Gulf Drug with expertise in pharmacy automation and supply solutions in United Arab Emirates, a graduate of Dubai Pharmacy College since 2016. Aya brings nearly 6 years of experience to her role. She provides expert guidance on best practices and share in-depth knowledge of automation systems, helping pharmacists, nurses to enhance their workflow and achieve maximum efficiency. Dr. Aya, the floor is yours.
First of all, Assalamu alaikum wa rahmatullahi wa barakatuh. Peace and blessings to everyone. Thank you, Sabrine, for the kind introduction. And I'm really honored and proud to be here and proud to be representing the health tech Serve. I'm really excited about this topic. As you may know, barcoding is a critical topic in healthcare, even when it comes to operation, regulatory compliance even, and most importantly, patient safety, which is the highlight of our topic today. So to save everyone's time, as I know everyone is excited to dig into the webinar, I'd like to first introduce our speaker. First, we'll have a webinar from the CEO, Victor Basso. He's the CEO and co-founder of OpusPack company, which is dedicated to the automation of hospital logistics and medication management pharmacy automation, which also Sabrine have showcased in the videos when it comes to automating and unit dosing, ampules, vials, and all types of medications dosage form. This is only a simple part of it. I'm sure Mr. Victor will highlight further in his amazing slides. He's the forefront of innovation where OpusPack company pioneered. He's even the director of OpusPack University, where he contributes to the education and training of future healthcare professionals. And he's even a great writer. He have accomplished and published a couple of books. I have one right now with me. I've been even using it sometimes from time to time as a reference. And he's coming with a new book. I believe it's called The Healthcare and Mindset, which we are really excited and looking forward for. Additionally, we have Dr. Abdullah Sheri. He's the Director of Pharmacy Services in King Fahd Medical City. And he is also, we can start with his pharmacy journey. He started his studies in KSA and furthered his studies when it comes to his PharmD and MBA in the States. And he has comprehensive background when it comes to clinical pharmacy and also when it comes to the leadership and management of healthcare facility. So we look forward for his valuable insights. To start immediately and not to take from everyone's time, Mr. Victor, the floor is yours. You can start the presentation.
Thank you, Tam. I'm going to share the screen like a beginning. Let me. Okay. I think you're seeing the screen.
Yes.
Thank you, Tam. Good evening. I want to thank you especially to IVPN network to let me address to this our audience related with the problem of unit dose or the process of unit dose in the hospital. I have been working for 15 years, like let me in like safety patient expert, and take all my company to be a leader in safety patient procedures, in methodologies, and things like that. So we are going to address to that. But from time to time, some people ask me, well, which is the thing you would like to make first? No? Okay, I think that in the healthcare there is no silver bullet because the hospital is a very complex environment. But it is very, very important to start with barcode in all operations. You are going to find that patient identification that is very important. It is a reduction of the errors in 80%. Dispensing for central pharmacy is up to 99% of reduction when you are using a barcode, and blood transfusion up to 93%. So using the barcode, it is imprescindible. That is, you have to do that like the first thing. There is no other way. So, we have some reasons for using unit dose. You know that there are many countries that still are working with boxes. Recently, we found that there is a country that they send to the rooms also the blister packs. That is the pack of 6 or 10 units. So when you have that, there is a lot of problems. And we are going to stress which is the advantage of using unit dose. First, because you have to put a barcode to control at the patient bedside, and trust only in the system. That is our true north. We don't work other way. The system is with the electronic system, the digital control is what had to give us all the assurance. There is another problem that the manager of the central pharmacy had to take into account. The pharmacy, the laboratories send to the hospitals the products with very little differentiation, and you cannot have that problems of LASA, look-alike and sound-alike products inside the hospital environment. So differentiation is a job number one or number two in the central pharmacy. We also use alert and advices like you are going to see now, to reduce adverse events. You can track each single unit with a serial number, and that is very important. You find one medicine out of the route at 9 p.m. and you check and say, okay, but this medicine should be given at 2 p.m. to this patient. So you are going deeper in what you can control. So track each single unit with serial. It is very important. You save time than cutting blister at the wards. You know that if you send the boxes to the ward, there is a nurse that is cutting. The nurse is a clinical professional that went to the university 4 or 5 years, and now is making a cutting that is delaying 1.5 to 2 minutes. And we can make that in the packaging room in 2 seconds with a professional that is not clinical. So you save time, very valuable time for the person that are with more load of work and should be attended all the patients. More than that, you don't lose control of each dose, because if you give a blister pack of 6 to the nurse, you, like the manager of the pharmacy, you lose the control of 5. So central control from the pharmacy, it is vital, and you have to prepare all the process in that terms. And finally, we have in many countries that we have the problem that is eliminated with this unit dose, because once you put a unit dose, you discard the box. And the box is not going to appear in the retail pharmacy out of the hospital, because the box have a commercial value. So you make the unit dose, you discard the box, and now you are quiet, you are safe that this is not going out. from all medical encounters, 10% is an adverse event. What is an adverse event? Adverse event is an error with harm. Who says that? Well, initially the World Health Organization is telling that, no, but there are a lot of organizations that are telling the same, and we have figures from some countries this is going up to 16%. And 50% of that adverse events are preventable. So it is very important to do something about that. From all the adverse events that you have in the hospital, 70% belongs to a lot of places and a lot of procedures inside the hospital. So you can correct that, but it's not easy because there are many root causes. So you have to change the culture, and probably in 2, 3, 4 years, you are going to do a nice job and you're going to reduce. But there is a process that is called medication that have 30% of the responsibility in the adverse events. And in this process of medication, it is easier to resolve the adverse events. This medication process is compounded by the prescription by the doctor, the dispensation by the central pharmacy, and the administration by the nurse. That's 58% that you have in the prescription. If you put the electronic prescription, it's going to be cut by half. If you put the barcode in the pharmacy for dispensation, that problem, that 2% is going to disappear. And then 40% also can be reduced. No? And Opus Pack is having in this part that makes the 12% of all the adverse events of the hospital, we are very much involved. Here you see which is our unit dose. It is being made with a material biodegradable. No? And in the back, you can see a transparent film. You can see the pill. But what happened? If the nurse want to open from that side, it's not going to be lucky because 75% of the probability that do not open in the first case, because from 4 sides, only one can be open. So you have to turn down to the face that is with letters, that is printed, and then you are going to find the arrow. And when you find the arrow, you know which is the side to open the unit dose. But at the same time, you are looking very clearly at the name of the medicine. And then, we use all the techniques of the Institute for Safe Medication Practices from the United States. We use the LASA, look alike and sound alike. We express in Arial 212 bold, and we use a combination of uppercase and lowercase for a better differentiation. So you have also the 2D barcode. GS1 is one of the most efficient, is what is being used now in many countries. And you have the legal data that we would say should be transferred digitally, because you have to remember that each time you are typing letters, each 250 letters, it is quite probable you are going to have one error. So transfer information by typing should be avoided as much as possible. And we have also the alert and advices. We have 200 types of alert and advices from our database of 2,000 medicines that is being used in many, many places. So this is our Opus Pack. It's a component with our methodologies, a component many systems to reduce adverse events. And here you are going to see some other examples. We have of this alert and advice. You have falling risk. No? Many medicines produce this falling risk. You have the exact time because you have to regard to this, and you have endovenosis law because if you don't say that and the nurse is giving fast, the patient can die. So in our understanding, you speak once, you speak twice, and if it's necessary, you speak 3 times because you had to be sure that there is not any mistake. So there is another thing also. There is a global trend in unit dose going from loose tablet to blistered meds and preserving the primary package. Why this is happening? Well, first, you have to eliminate the risk of cross-contamination because when you are using compressed pills, no, they disintegrate easily. You create a build-up in the dropping funnels of powder that once they drop at a time, no, enter in the unit dose and make a contamination. So that it is not recommended. You also have the convenience that you eliminate the clean room because if you are using a loose tablet, you have to use a clean room. That is the rule. And you eliminate the risk of biological contamination because during the time you have this pill in the air, no, there is also problems of contamination. And now with our robotic machines, you can cut automatically and do not increase the cost. You can do that very easily. So also you don't lose validity time because in many countries you lose 75%, no, of the validity time remaining because you are taking out of the blister and use it in loose tablets. And you have also protection against the light and humidity. So that is why we are seeing in many countries there is a trending to conserve the primary package and keeping that way. And here we can see there is all the process involved from the beginning up to the bedside, in order to assure that we are with the file rights. First, you check the barcode in the box. The box, the commercial box that you receive, could have a linear barcode or a 2D barcode. That barcode should match, it is not equal, at least should match with the barcode that is in the unit dose. So, because you are going to check at the end of the process, you are going to check all referred to that barcode. So the machine is going to control that because it's the system and not the operator that confirms that the match of the barcodes. So you have in the machine at the exiting of the unit dose, you have a scanner. No? This is something that is new in our machines. You have a scanner. You control that the barcode that is printed match with the barcode in the box. So when the nurse is at the bedside and check with her system, he check the wristband, no? So confirm the patient, confirm the medicine, confirm the dose. The VIA is advised by Opus Pack alert and advices, no? And you later are going to control the right time with the his. And so you are going to have the far right under control. And this is our machine for is IVAC Pro. And you have to think that one machine, one operator, one shift is able to supply up to 600 bed hospital for all its solid organs. And two machines are capable to supply 1,200 beds. So it is very easy now to resolve this. But also we have a machine for ampoules, for labels for ampoules, because ampoules, it is a high risk. 70% of the very bad, and very bad events, adverse events, is related to ampoules. So ampoules also have a reading that is very difficult. So you have to put another label. You add some alert and advice. You put your own barcode, and then you have a better quality and better patient safety. We have also a machine for unit dose for oral liquids, syrups, and suspensions, but only enteral. And what we would recommend is the reading of these two books. The Opus Pack system have 27 different methodologies to reduce adverse events. Are criteria collected from Opus Pack, some from other system, and from our own. And you have to think that in Brazil, we are using unit dose since 1992. So there is a very long time, 32 years, that we are using. That is the reason why we grew and we grew strongly in the world, because Brazil, there is 210 million people, is using for more than 30 years unit dose. And we recommend to read the Lean Healthcare Culture book, because this is giving you quality and is for reducing waste. And if you reducing weight, you increase your result. So these are some of the books that we have. We have several people writing books in our, and we are going to have 4 more of these in the next year. No, so this literature is free, have no publicity. You can enter in our university, and you can download these for free. Many of these are also in several languages. And here we see the root of the medicine in the hospital, and it's only to say that we have something that is being launching in this moment, is that the Be Blue platform. And what is Be Blue platform? It's a system that you can add and integrate with your HIS system in order to control things that you are not controlling with the system. And which are that elements? First, we control digitally all the small flows, all the small stocks. And this gives us another view, and there are many things that we can find and we can resolve to reduce waste, because we are controlling very small parts of the process. So here, from the entrance to go to only those room, then we create the batch bag. That is what we store in the pharmacy stock center. That is close to the picking area. In the picking area, we create the patient bag. And what is the patient bag? It's a bag that is written in all the name of the patient, all the medicine that is inside. Normally is 4 to 6 medicine, because with this patient bag, it is being delivered to the wards 4 to 6 times per day. No? in order to reduce devolutions. So that patient bag then goes to the wards in the transport car, and then the nurse is taking that and loading in their own car. And so you are going to have all what I say, the barcode and the control, in the bed of the patient. And here is in only for synthesize that normally the hospital have 30% of waste, and if they are lucky, have 10% of results. So, and in all the world, there is a general claim about more results. And what is happening that if you reduce from 30 to 20% the waste, you double your profit or your saving. And that is very important for the economic health of the healthcare industry. So thank you to you, and I now open to your questions.
Thank you so much, Mr. Victor, for the great presentation. We will be now starting our discussion with Mr. Victor and Dr. Abdullah. And if anyone has any question, please feel free to react or write in the chat. Myself, I have a set of questions ready from what I've seen, and I would like also to hear Mr. Victor and Dr. Abdullah's feedback on this. Okay, so to start with the first question, and this goes to you both, Dr. Abdullah and Mr. Victor. Mr. Victor, from your perspective, since you've been in the industry for so long, and Dr. Abdullah being a leader when it comes in the facility, what is the biggest barrier you see when you want to let the facility adopt the concept of barcoding or automating the barcoding concept? What do you see as a barrier when you come to a facility and you tell them, okay, we have this new solution and we recommend you to implement it? And similarly, Dr. Abdullah, when you decided to implement this into your facility, what is the barrier you have faced? Mr. Victor, do you have any feedback on this?
Okay, yes, I was expecting Abdullah. Well, we recently arrived at a country with our first machine, and we knew that all the country is delivering boxes. No, I am not going to mention which is the country, but to know which are the barriers, it is very, very important for us. I would say that most of the time the people have a resistance to things or to process that they do not know very well. So I am a fan of first install the culture. First install the culture about safety, about what you can improve with that, and explain that to all the people, also doctors, not only digamos people in the logistic, because unit dose is not automation of unit dose. It's not for reducing people. That is a wrong approach. What we say is that you have to reduce adverse events. According to some organizations, adverse events are having a cost very high, higher than 10% of the cost in the hospital. You have to think that if 10% of the interaction have one of adverse events, and 50% of them are serious, that you are going to keep the person 2, 3, 4 days more, probably in ICU. That is a high cost. So more than the responsibility, the moral responsibility, there is a cost. And we emphasize the issue of cost because normally the persons in the corporate part, the corporate sector of the hospital look more to the economy than other things. If we demonstrate the economic, it is easier to demonstrate because it's going to be much better for safety and for you know, the patient is the first victim, and the person that work in the hospital, the nurse, is the second victim. So it is very important for the moral of the people that work in the hospital, reduce adverse events, and know that all the hospital is involved in a reduction of adverse events.
Thank you so much, Sir Victor. I completely agree. And also the pharmacy will also be impacted. Also, Dr. Abdullah, what's your feedback?
So thank you, Victor, for this informative presentation. Thank you, Aya, as well. Whenever we speak about challenges, I think there's two set of challenges before delivery and after delivery of those solutions. So whenever we are going to get a machine that will serve any purpose in pharmacy or any department within the hospital, we need to convince the management and also convince our finance department and procurement department and our supply chain, all those stakeholders. They have to be included in this decision and to kind of like gather votes to push for your project. So I think this kind of like sometimes it's actually most of the time it's challenging, and due to different reasons. So you know sometimes budget allocation, you don't have enough budget allocation. Sometimes they have another set of priority. You have to look at them before they move to your project. Sometimes there is no understanding of the importance of those projects. Specifically in the hospital, we are speaking about different discipline. We're speaking about physician, pathologist, lab technicians, pharmacists, finance people, like all these type, like they come from different backgrounds. So it's important always to have those people like involved, to have a good communication with them, and provide a good explanation. And always I call it like it's a case, you take it in the courthouse. You are the lawyer of your case and you have to defend it in front of the judge and the jury. So it's always like a pursuit to have or like to have buy-ins, like or like to bring stakeholders buy-ins into your project. This will help to, as I mentioned, to or like it will help to allocate fund, expedite delivery, facilitate some technical specifications. Specifically, when we look at the place that we're going to install the machine, we need help from biomedical engineers as well to look at some requirements before we bring the device or the hardware itself. Then we have to move to IT engineers to look at how we can operate or how we can run this machine before we even get the delivery. So once we get the delivery, now we move to another set of challenges that also come in place whenever you get a new solution or new path or workflow into your workplace. And I believe that culture is one main factor. Also, we need to, or like what we learn actually is also to have our feedback from end user. Always we need to make sure that or like we need to have involvement from our stakeholders or end users. For instance, as us for pharmacy, we always look at patients in outpatient setting and nurses for inpatient settings. Those people, they need to understand what's the purpose of those solutions, why we do have them, so they can help you to deliver or to help you success or like to make this project successful. Before that, we need to look inside the pharmacy and we need to make sure that the pharmacist and the pharmacist technician are aware about what's going on. They sometimes feel, as Victor mentioned, that it's a replacement of human, but in fact, it's an aid. It's help you to do better, to provide better quality, and to take care or to take more care of your patients. And if a machine can do the job for you, let the machine do it. All it needs just like to pay attention how it works, make sure it has like just clean output, and also to adopt the model or like a new implementation into the workflow. So I think these are the things that you need always look at. And before we start this session, I think, as mentioned to you, I like leadership involvement is essential in each step of in each step of this, or in each part of, or like section of these challenges. We need a push. We need to defend our case. We need to explain. We need to communicate. We need to speak to all stakeholders before delivery and after delivery, as mentioned, to make sure that all those people are involved, they are convinced with your solution. Otherwise, it's not going to happen. So this is basically it.
Thank you so much, Dr. Abdullah, for the insight. And I just, if you allow me to add, especially to the section of changing the culture on the mindset or the people worrying from automation, regardless if it's barcoding or any other solution, I think it's also opened new doors for pharmacists within the facility. So did it allow them like to move more into clinical tasks or even allow them to be more into informatics tasks? So I think it also opened some more doors to pharmacists as well, if it's doing also some of the main tasks.
I agree with you. That's actually this is the main goal, as I said, because always pharmacy has two components. We always need to. I always try to emphasize for everyone that the pharmacy has two components. We have operational component and we have clinical component. However, if we work in large facility like King Bed Medical City, like in our hospital, we have a high number of patients. Operations sometimes drag people more, or like to make us kind of like fail to fulfill our clinical commitment. So I believe those solutions, if a machine can do a job for me, let the machine do it. By this, I can deploy my pharmacist and even my pharmacist technician as well to more valuable work. As I mentioned, Victor, like as Victor mentioned that if I have this example, like he mentioned that example with nurses, but it's applicable across the way with even with pharmacists. It's actually sometimes unfair to have a pharmacist or a technician to cut a blister, or to package a blister, or to put a barcode, or to tag it with a name or expiry date. Those people didn't go to school, and they didn't learn, and they didn't spend like significant amount of their time learning to practice this type of businesses. They are more equipped, they are more ready to practice more advanced duties other than operations. And I think when we look across the board, even like when we look at like even the aviation industry or in car manufacturing or any type of manufacturing, you can see all production line now are moving toward automation. So now they can have their engineers available to think about innovative projects or innovative solutions or to resolve their solutions. So healthcare is just going in parallel with the trend across the world, across different industries. And this will help us actually to bring more valuable solutions to our patients.
So speaking of AI and healthcare, Mr. Victor, do you think that there will be more in the future implemented even within the barcoding solutions? Will we have AI implemented into the solutions? Do you believe this will be done or possible? Or can
Of
we
course,
consider
there
also
is
BPO as an AI tool?
there is a lot of things that are coming AI related to the clinical jobs. But let us understand it. I agree with Dr. Abdullah. No? Let us understand it. And in this way, perhaps we, like industrial people, we can help with some ideas to the healthcare industry. And that is the motive or the book that you mentioned, that is Healthcare Mindset. No? We are living in an exponential time. Things perhaps today are good for you, but the level of complexity is growing exponentially. And that is going to happen also in hospital. the amount of new technology, new methodologies, new approaches, new things that are appearing in the following 10 years is going to be very difficult to cope with all that amount of advances. In the other side, the hospital have the problem of, in all over the world, the increase of the age, no, the increase of the disease that are how we call generative disease, that chronic disease, no, and the increase that some technologies and some procedures, medical procedures, are more expensive. So in front of that, you had to have some ideas to resolve. And also are ethical issues about that. But let us put the ethical issues at the side, no, and go to something that Dr. Abdullah mentioned of what in this industry, what is the automation. First, no, the the 50% or 40 or 60, like you think, part of the hospital is not clinical. It's an activity like any other industry. You have human resources, you have logistics, you have administrative department, you have cleaning, you have safety personnel, you have engineering. No, it is like it is not people that had to have some time to stay close to the patient to understand which is that triage is given. Mm. So there are some operations like any other industry. So my question is, it is the hospital treating that operations like any other industry, or is treating with a bias of clinical understanding? And I'm going to put an example. No? Are we doing all the standardization of process that are required? Or we continue thinking that one patient is one issue, one sickness is one issue, and we have to resolve one by one. So if that approach of resolving the issues one by one enter in the part of the corporate, or the part that is equal to any other industries, it is not good. So I think that industry, when you put assemble a process, you take times. No? How many times did you see in the hospital take with a people with a chronometer taking times? No, that is not going to happen. But I saw people working 30% of the efficiency for a lot of years, and nobody claimed because he was complying with the quota that should be that it was required by the hospital. So there are many things that if you talk about the assembly lines, there is a history of Robert McNamara that worked for many years in General Motors, or in Ford, I don't know, and then entering the bank like a director or president of the bank, and he say, "Where are my assembly lines?" And I would say, "Where are the assembly lines in the hospital?" No, we cannot do that. No, not physically. I am not talking physically, that some things can be done physically. I think that put the process, the solutions in line, of professionals in order to give a flow. And when you work in lean, you learn that the flow should be even. If you receive all the people at 8 in the morning, and you are contracting people resources for that peak of that amount of people that is coming, well, it is not a good decision. So if we move in the hospital to the medicine by value and presting everything with related to value medicine, then perhaps we can concentrate some specialties in some part of the hospital or in some hospitals in order to make the assembly line for that. But you need an amount of people. And if you work everything to everybody that is entering the hospital, it is not good. Perhaps you have to select, create an organization for this and this and the other. And in a very simple case, I live in Spain also some part of the year. I went to my cardiology, and he was having in the same room, operated by himself, a machine, that sound machine to control, and so that's it. It was not necessary to send to other part of the hospital to make that control and that triaging. So there are simple things that perhaps you had to put in order to create the assembly line. Everything together, everything working for an amount of similarities, and there is existing an amount of similarities. There is some surge of problems that takes to create a big solution in specialties. And I used to say, if you increase the amount of specialties in the hospital, in terms of industry, understanding of industry, you are getting less and less specialized. So many hospitals have the way that they want to grow, increasing specialties. Okay, this is some part of the understanding. I am not have the true. I am not have all the last answer. I am telling that you have to balance. You have to consider that perhaps it is preferable that some specialties is being made for other facility, and you concentrate in some other problems. So culture is the first issue. You have to create the culture. And the culture that we have to give to the hospitals is a culture that something should be changed now and very fast, because the complexity is growing exponentially and there is no time. It will happen the same like in the weather. In the weather, we lose time, and in some moment, we are looking at the result, you know, and the consequences of these. And when you arrive at the break-even point, there is no more option for incremental and linear solution. You have to think exponentially. You have to think in a way that we need to change that. So I propose make a lot of small changes, and that is going to be an important change.
Thank you so much, Mr. Victor, for your input. So I'll move now to the questions in the chat. We have several questions, and the first question is from Dr. Ahmed Abdul Tawab. He's asking, what are the limitations of using such innovative solutions or machines? Did you face any limitations, Dr. Abdullah?
So I think sure there is like I would say like a couple of limitations. Maybe the first thing now comes to my head is that space. You cannot just have like a solution or like the limitation or like you cannot have any machine, especially those machines come kind of like sizable machines. So space sometimes cannot help you. Maybe you have all things, you get all things set up, but or like all problem like were resolved except space. So this is one of the things that sometimes you need to look at it. The other limitation, as I mentioned, that is buy-in from different stakeholders. Those are things that really it's essential and it's important. Also, the other than that is that we cannot have only one solution to resolve all these problems. So when we speak about, let's say, like unit dose packaging, I like it's difficult to have one machine or one size fits all. So this is one of the limitation also we have, that we need to we spend a lot of time to look up different solutions for different purposes. So this actually takes a lot of time, and it took like a lot of time and communication or conversation with everyone to make sure that we have the appropriate solution. So making a decision sometimes is kind of like it has to be like a thoughtful decision. You have to make sure that all these limitations has been addressed. As you can see, like eventually you are enclosed ecosystem within the hospital. So everything could impact you. If the system fails, that means it fails forever. Like you cannot just reallocate it or change it or change the owner or change whatever to use it. If it fails, it fails. That's it. That's it for us. So those are the things that we usually look at, or like when we think about limitations.
Okay, great. And we have another question here from Dr. Marwa. She said, could you please provide more details about, I'm sorry, Sabrine, before I move on, I think you raised your hand. My apologies. Please, Sabrine.
No problem. I just maybe want to add about the reporting system, Dr. Abdullah. Maybe this is one of the most important things that you need in the pharmacy to make sure that we are using the machines in the most effective way, and how it change, and how can we document the efficiency of these machines. Maybe we need always to improve the reporting system. I don't know if the vBlue system or software can help in the elevating the bars of reporting system of these machines to help the pharmacy in the future to optimize the workflow and the logistic system of the pharmacy. I think this is one of the challenges we have.
So I agree with you, Sabrine, but I'm always very cautious with all solutions, either like IT solutions or hardware solutions.
Yeah.
It's always kind of like, do I really need it? Do I really like my work? Like I will be more efficient or more productive if I have it. On top of that, I think about after 5 years, I'm still gonna use it or no? Is this a sustainable solution or no? Do I have a replacement? Can I have allocate this solution internally? Can I have something internally? It will be much easier, free of charge, and just like can search some sort of optimization to my solutions. Like we can use our HIS system, or we can have any other system we have, or even SharePoint, anything that can help to resolve these issues. So it's always about, do we really need this solution or no? And do I need it after 5 years or no?
Thank you.
Maybe one added thing I would like to mention, the amount of work it needs, because each solution comes with its like volume of work. So sometimes those solution maybe has more work than what I'm doing now. So this is also one thing I have to look at. So if I need to go check 2 portals to obtain a system or like a report, while I can just optimize my current portal to obtain this report, this will be way better for me. So it's always like, even like, does it gonna have an organic implementation in my workflow? I don't need to jump from screen to screen or from location to location or place to place to get this done. If I can do it at one place, even with more labor work, I would maybe like will be more, I maybe will be leaning toward this type of solution if it's have organic implementation in my workflow.
Yeah, I believe also integration is extremely important. If the solutions are also able to integrate with the hospital information system, because as Dr. Marwa also mentioned in the chat, we have now the regulatory is asking for barcoding or unit dosing all type of medications like Rasad, and even in UAE we have something called Tatmin. So from the moment it leaves the facility till the moment it reaches the patient, everything needs to be traced and integrated. So I think it's also important that the new solutions or the current solutions are able to integrate with the facility's health information system, or to integrate directly with these systems in order to provide the needed update.
Yes, agree with you.
So I'm hoping also Blue also
Uh,
has impact on that.
I agree with Dr. Abdullah. We emphasize do not sell more technology that is being required because we know more about the process and how our process affect. And so we are worried and we teach all our sales people, no, keep it simple, no, because you don't have to have more technology that is being required. But of course, a big hospital needs some special things that are with high production. So that is clear. But we have many cases that with simpler solutions are okay. So I totally agree that the function, the drive of the person that is in charge, he had to have an equilibrium between one thing and the other. Despite internet technology or IT it is totally necessary, is something that we are going to see more and more growing on that, because there is a need to reduce expense and to control more things. No, and I think that AI will give us more access, so more information that could be processed and understood in a better way.
So just a reflection of what you just mentioned, Victor and Aya, that those solutions, do we need them and do we need to integrate them and all these things? So for us at KFMC, and this is our case, it could be different. Some hospitals maybe have different opinion, but all packaging machines are not integrated with our system. So we move with this solution after like a deep conversation with the team, which pathway we should go with. Then we looked at if we integrate those machines, we are talking about maybe 5 or 6 machines. So each one maybe from 3 or 4 different manufacturers. Okay. So when we go with system integration, that's mean I have to go through a lot of integration processes with different requirements from each manufacturer. And those will consume a lot of time for us working just to build the system. On top of that, our inventory or our supply chain is very complex by itself. So we don't want to add more complexity to our operation and to make all these things like to make everyone life hard. So we chose that. Let's think what's the common factor or what's the thing that we can obtain from all solutions, including our HIS, that can help and integrate our solutions. So the solution or like the answer was actually ready, that just use kind of like any standardizations that can be transferred or can be translated from one machine to another. That's why now we are following JS1 code, even with our machine, like we follow JS1 code and JS code. This will help us to like kind of like virtually integrate all these solutions. We can have kind of like proper monitoring of our stock movement. And by this, we be more efficient with our time. Because whenever we go with full integration, I would say like rather than starting today, I might need another year to go live, just to finalize the integration itself. Maybe I have the machine, I have the infrastructure, I have everything, But if you cannot integrate it, I cannot work with it. That's mean that I have to wait. And I know IT are busy with a lot of things. So I know for sure this is going to take a lot of time. So we just picked what's going to help us to track our operations, and we find there's this code it's movable, it's readable, it's every system can understand it. So we just went with this type of solution. So this is the thing that also I wanted to emphasize, reflection to integration or system integration.
So
Yes, it is. There
go
are
ahead.
many levels of integration. That is what our machines actually are integrated with the printer. So you can put the printer that being handled by the HIS system. But we are moving forward to have further integration with the machines. No, you have a machine that is for printing codes in paper or things like that that is not integrated, but many all the other machines are integrated, and we are moving to be more integrated. By I want to say that your concern it is very deep in our understanding. No? We used to say in our company that we need the bike. Why we need the bike? Because the bike is simple, it's cheap, it is ecological, and we immediately know if what part is broken. No? So of course, if you need to make a big machine, but if you have that concept that things should be simple, no, at each stage, you arrive to have simpler solutions. Besides, it is a big machine or important machine with complex operation, but you are going to have something more simple. So I understand that, and we are found to work in that way because the later you need people to handle all technology. So the best machine for a user is something that open the door and the inside it is empty. It is nothing. Because if you have something, there's something that you have to manage, to repair, to correct, and to regulate. You know? So I understand totally fully what you say, and we work with that way. I don't know if we are reaching your standards, but we are working with that purpose.
I'm sure it's gonna happen and we'll reach everyone's standard, inshallah. And just checking on the when it comes to monitoring, then how does your organization handle the discrepancies and error, and how do you monitor its effective? Oh, sorry, I mixed two questions together. My apology. So from Dr. Hayat, we have a question about how does your organization monitor the effectiveness of the medication barcoding standardization, since you have mentioned what you have faced. So how do you monitor and improve? I believe this question is Dr. Abdullah.
It's for me, right? I
Yeah,
believe.
yeah, yeah.
So actually, the best way to monitor the effectiveness of those solutions is to measure the output. That's the best thing we can do. So for barcoding solution, we are implementing those barcode into so just to bring everyone like to speed, that we have inpatient and outpatient pharmacy, and both use barcoding system. They both use different barcoding system. One use the unit dose barcoding system, and one use the bulk or the package barcode system. In patient settings, we are measuring the effectiveness, or like we are working with this, or like to measure the effectiveness through different steps. So the first one is dispense prep, or like with dispense preparation. So it has to be scanned. That's mean the percentage of scanning of medications that can reflect how effective is the barcoding system. The other approach is at administration, which are going, or like which we call it barcode medication administration, BCMA. So currently we are finalized or like we done with PCMA. Now we are reaching about 96 to 97% on daily level, on daily basis of barcoding or like barcoded administered doses. So at our institution, we are talking about average 11 to 12,000 doses per day. So that's mean all these doses, 97% of these doses are scannable upon administration. Keep in mind that we are barcoding tablet, capsules, ampules, vials, syrup, suspension. But on top of that, we are also packaging or barcoding IV preparations and chemo preparations and fluids, all these things. So when I talk about this percentage, that's mean we are seeing how effective our approach by measuring how much scannable doses upon administration. We are now working with dispense preparation, which is going to be inside the pharmacy. It's kind of like an expansion. We kind of like we looked like different, like we worked different way. Like we worked from the administration and went back to dispense. But due to some sort of urgencies, like in our operation, we need to move, or like we had to start with enforcing barcode at administration, and now we are working to enforce barcode at or barcode scanning at this or like at preparation. Although the barcode is there, so going back to my first question is the culture. So now we are working with the pharmacy. We are done with the nurses in the barcode medication administration. We did a great job with them. They are like very excellent team, very nice people. We worked together. We did it. And now actually we are working internally within the pharmacy to measure the effectiveness or like of the barcode scanning or like barcoding solution within the pharmacy itself to help minimize errors associated with dispensing. So now we are done with, or like we work with the section of safety related to administration, and now we are trying to address errors related to dispensing. This when we talk about inpatients. When we move to outpatient settings, actually, and now we are reaching about 70% of outpatient dispenses actually are barcode or like scanned by barcodes. And we are working also as well to have also to enforce scanning upon preparation. So I think this is the best way to measure the effectiveness of those codes. The other thing also we have our channels like it's open all the time for all nurses and pharmacy staff. If they have any issue, they can escalate it. So we have about like basically we have WhatsApp group for all reports that related to barcode or like if the barcode is malfunctioning, it can be reported right away. At the beginning, we used to have a lot of feedback, a lot of issues, but like lately now we are doing good actually. Like our barcode are optimized, are functioning, are doing good. So I think now or this is how we manage the effectiveness of our barcoding system.
That's great. And yes, just to add on, at every implementation of every automation, what we noticed also from our experience, it takes 3 months to 6 months until you see the error rate decrease. And I also agree about the WhatsApp group. I found it also very effective when we go live because everyone having their phones and they can immediately just send whatever error or problem they might face. So it's also considered, I believe, as an effective manner. And when it comes to, since you have everything monitored and everything is GS1 barcoded, do you face any discrepancies or errors? And what are the corrective actions? Like, what do you do after you see an error? Like, what kind of actions are being taken, or how do you manage discrepancies? This is a question also from Dr. Hayat.
We run into a couple of discrepancies throughout our processes. Sometimes due to implementation or sometimes manual transfer of barcode from the package to machine itself. Sometimes we need some manual involvement or manual intervention. Also, we were trying to also how to translate a package barcode to a unit dose barcode and to have it traceable. So let's say the package has 100 tablets. So how we can replicate this barcode 100 times to use it for those tablets or ampules or vial or whatever. So those are one of the discrepancies we faced across the board. I think one of the discrepancy as well we are working with now, it's not actually affecting our operations, but actually we are working with those barcode to be reflected in our inventory. So this is one of the things that we are trying to work with. We are working with it in the background. It's not affecting anything in our operation, but this is one of the things that we are working with now to also have kind of like a closed loop of our inventory. So whenever a medication is administered or dispensed, it can be automatically deducted from the whole series of our supply chain within the pharmacy and outside.
Thank you, Dr. Abdullah. One last question we have from Dr. Marwa. She's asking if you please could give us more details about the financial impact of implementing these innovative solutions in the private healthcare facilities. So mostly about the impact and the cost benefits. If we can have some data shared.
So actually, I don't have the data on me now. One of the reasons that like in Saudi Arabia, we have a public health care, so sometimes we don't have the value for each services and each step we have in our operation. However, you need to keep in mind that I cannot say like all these solutions, or I can say like yeah, it maybe be more cost beneficial because we are kind of like currently we are working in equilibrium. We're still the same. We still I mean like we're still using the same, or like the value or the cost was moved from one service to another one. Let me explain what I mean is that when you get those solutions, they need consumables. So these consumables actually cost money, or like they come with a cost. I cannot we cannot say like okay, it's gonna eliminate something in our operation. We used in the past to use some type or different type of barcoding, and now or like different machine of barcoding, and we moved to another type of machines that help in barcoding. So when you look at the direct cost, we need to be careful because it doesn't mean that we eliminated something in our operation. However, we need to look further to look at the outcomes from enforcing or implementing or advancing barcoding within the pharmacy. So for instance, I can, like we don't have it now, but I know the cost of reducing medication error associated with administration can have a good impact or great impact on our cost benefit. The next step, when we also imply barcoding and preparation as well, that's mean we will reduce error associated with preparation and medication preparation. This will have another cost on the process itself. So currently, we don't have the data, like we don't have the whole data. Actually, we are kind of like we just start working with this type of business within the last 18 months. Like one of the things that really I would like to share or like to mention that our packaging capacity was about 2,000 unit dose per week, and now we move it to 50,000 unit dose per week. So there is a huge jump in our operation. It's really hard to measure the effect now, or like to balance it out, or like to get a clear output from this data. So that's why we are kind of like we are looking kind of like in a high level of the cost, like the cost benefit from a high level perspective. We didn't go deep so far until we really. I believe like we're still like we are kind of like stable now, but we need some time to compare data after we stabilize the operation and the data way before we started. So we have to go back 2 years and look at the data, and 2 years from now or 1 year and look at the data. In transition period, this one, it's hard to measure the cost or compare it or to put it in analysis with current stable state.
I think it will be amazing if, inshallah, after a year or so, you'll be able to even publish it as a study. I feel in the Middle East region specifically, we lack when it comes to information from our end to share. Like, so I hope with the amazing jump and everything you see that you'll be able to have that done. We keep having questions and we're sorry to take from your time. We're going to take one last question. Since you have mentioned the management of barcoding, Dr. Abdullah is asking, what is the difficulty your organization faced during to add or register all medications barcode to the HIS? Were they already registered, or you and then you added the barcodes, or it was the opposite cycle? Because some facilities have already everything in the HIS already.
No, actually, it's part of our inventory module. So within the pharmacy, we have our own inventory module aside of the ERP of the hospital itself. So for Epic, we have Epic Inpatient, Epic Ambulatory, and Epic Inventory. So we are utilizing Epic Inventory now to control our barcoding system, or like to define our barcodes, because our ERP does not recognize barcode or doesn't look at the barcode itself. They manage their processes in a different way. It's their business. I respected this. So we had to do it ourselves. So our processes now is that to have a kind of like a checkpoint whenever we have a new shipment from the main warehouse to the pharmacy warehouse or pharmacy store, we have a checkpoint. Each delivery has to be assessed for their barcode validity. And we have a pathway. If the barcode is not recognized, we have a pathway with our friends in Epic that to define and validate those barcodes. So this I think we actually do now because so basically we do it ourselves. Just like this is my answer in a nutshell.
But when you say checkpoint, I'm sorry, you have like someone checking each and barcode after you receive it. Like they
Yes.
scan it into the HIS.
Yes, each delivery, because we have to log it in the system for inventory purposes, actually.
Okay.
But as a kind of like a biggie bag that barcode can be defined on those machines.
Okay. Thank you so much, Dr. Abdullah and Mr. Victor, for your valuable insights. Really, it was a great discussion. I'm not sure, Sabrine, if you'd like to have anything to add, but we really learned a lot from our end. And I believe we answered all the questions or most of them when it came to the discussion. So thank you all for joining us and thank you for your time. It's really highly appreciated.
Thank you so much. Thank you, Aya.
Thank you.
Thank you, Victor.
Thank you,
Thank you, Dr.
Raya.
Abdullah.
Thank you so
Thank
much.
you.
And just
Thank you, Doctor.
Just to add, we would like to share that by the end of the webinar, we'll be also sharing the OPUSPAC University books, the Lean Healthcare, to everyone registered in this webinar, and you shall receive it also to your emails, inshallah.
Thank you,
But
Aya.
thank you so much all for your time. I really enjoyed it, so thank you.
Thank you so much.
Thank you.
Thank you very much.
Have a good day.
Have a nice evening and a good day.
Yeah.
Bye-bye.
Bye-bye.